The etiopathophysiciology of this condition, that is similar to carcinoma buccal mucosa, that is smoking, alcohol, pre-malignant conditional leukoplakia, erythroplakia, and oral submucosal fibrosis. Most commonly, we saw involvement of lateral margin in 47 to 50% of patients, followed by involvement of posterior one-third of tongue in 20% of patients. Now, types, we have gross types and histopathological types. Under gross, we have papillary type, ulcerative type, fissured type, and lobulated type. Under histopathological type, we have squamous cell carcinoma, adenocarcinoma, and melanoma. Then we saw the primary lesion, which can be ulcer or swelling. It is usually painless. If it is painful, it indicates involvement of lingual nerve and secondary infection. The ulcer is having everted edge, indurate, and the base is indurated, and it bleeds on touch. We have excessive salivation in these patients due to this ulcer and swelling. If we see halitosis, it's due to necrosis of the lesion, which releases ammonia, butyric acid, and mercaptan. And also, if the tumor involves posterior one-third of the tongue, the patient may complain of pain on swallowing, odynophagia. C. Spread, that is local spread and lymphatic spread. The local spread in case of anterior one-third of tongue will cause dysphagia if it involves genioglossus muscle. The involvement of other tongue muscles causes ankyloglossus, which causes difficulty in articulating words. The involvement of posterior one-third of tongue causes spread to tonsils, pharynx, larynx, and cervical spine. The lymph node spread, we saw it spread to submental lymph node, submandibular lymph node, upper deep cervical lymph nodes, and pharyngeal group of lymph nodes. We saw tip as bilateral spread to contralateral one, and also central part of anterior one-third of tongue will also spread to contralateral lymph nodes. The management, we saw investigation, wedge biopsy, FNSC, direct indirect laryngoscopy, MRI, CT scan, chest X-ray, and orthopentogram. And the treatment, we saw surgical excision, that is wide local excision. If it is less than 1 centimeter, we perform wide local excision with 1 centimeter margin. If it is more than 2 centimeter, between 1 to 2 centimeter, we perform wide local excision with 2 centimeter margin. And if it is more than 2 centimeter, we perform hemiglossectomy. The lymph nodes, we saw if it is ipsilateral lymph node involvement, we do radical lymph node dissection of that side. If it is bilateral involvement, the ipsilateral side we do radical lymph node dissection, and contralateral side we do modified radical lymph node dissection. Radiotherapy, we saw radioadjuvant and small, if the lesion small, we give curative radiotherapy. Chemotherapy, we have one regimen called as Prince Hill regimen, where you methotrexate, vincristine, adriamycin, bleomycin, and mercaptopurine. This is all about carcinoma of tongue.